So I come from Madrid. I'm so pleased to be here with all these big names. And I don't want to boring you more than now. Maybe you are taking a nap, like we are doing in Spain actually at this time. So I don't want to repeat the same concept again. This is my disclosures. I agree in many of the things that my previous colleagues mentioned. In aseptic loosening, I try to do not remove the fixed components. That's the same that they say. And for the infection, I try to remove both. This is the first answer to the first question. What about some special situations? So, for example, in these cases that we have resurfacing metal-on-metal replacement in the left side, we have these metal ions problems, and sometimes with these cases, I have some concern about the mismatch between the components, what to do, to remove the acetabular side or not. So in this case, we remove the femoral side. That is very easy when it's loosening. And for the acetabular part, in this special case, because I'm not sure about the mismatch about the size of the component, we use these tools that have been mentioned here, the EZ out, and it's very easy to remove these well-fixed big acetabular components. So sometimes it's much better to remove it than to have the concern that you have more problems, especially in this very sensitive problem with the metal ions. If you put a new component and you have again an increase of metal ions or any problem with the mismatch of the components, maybe you will go to the court. So in the acetabular side, in the standard revision, I use uncemented components usually. This kind of metal augments is my first choice, with different options that have been mentioned here. And sometimes, in very special cases, I cement the previous liner. When you have a very fixed liner in an old patient, that the removal of the component will create more problem than you have before. Maybe in that situation, you have to think about doing something different to cement a component in this well-fixed uncemented. And for sure, you have to do it correctly. I mean, this is a technique to do it. You have to prepare the liner and do it correctly. And what about these young patients with this bone defect? So I would bet for this impact shock grafting. I think to put bone and restored bone stock in these patients is a good option, thinking in the future revisions. So try to do this very simple technique and do it correctly, and you will have more bone stock for the next revision in these very young patients. For the femoral side, I would prefer uncemented. I mean, most of my cases, uncemented implant is my first choice, and I will say you why I use this kind of modular implants that they fix in the distal part of the femur. Sometimes, for the femoral side, we use cemented one, especially when you have a second stage infection or a poor bone quality. Cement in cement mantle, well, there are some times that you have to use it, but if it's a long-term aseptic loosening of these implants, the cement mantle usually is not very well done, and then you cannot do this technique correctly. So the case where I found this mantle correct is in these dire situations, infected situation in acute implant. And why I use this uncemented femoral stem fixed distally, the Wagner type, because I like to use this extensive extended trochanter osteotomy. I do that because sometimes it's very simple, it's quicker, and I work in a public hospital, and we cannot afford the Oscar system or system like that because are very expensive. So with these systems, I can do a good approach to the stem, remove the cement or the uncemented implant, and use these distal fixation stems to do the correction. This is maybe the only thing that I disagree a little bit with my colleagues and how I approach the revisions. For sure, you have to do a correct stentotracheal osteotomy and a well fix, and the complication with this technique is not allowed. I mean, the patient doing well, I mean, the osteotomy fixed very well, and I think it's a good option if you don't have these very interesting tools like the Oscar. What about the dual mobility? Well, if you revise an unstable total hip replacement, for sure, you have to use it. To be honest, I'm not using the monoblock dual mobility. I usually use the modular one. And for the unstable is the option, I think. You can see intraoperative how stable are these patients with this dual mobility in these situations. And when you are using, again, this two-stage infected revision, as Mustafa said, maybe you have to think about to do this dual mobility because the soft tissue around are so weak. And finally, in very special situations, primaries or revisions, with some problems in the lumbar spine, for sure, don't take the risk. Go to the dual mobility. These are my main principles. Again, these revisions, when you have a failed synthesis, again, use this dual mobility. Thank you so much.